We'll be looking at the overdose survivors' accounts on toxic supply and safe consumption, which is extremely important. And it's important because globally, we are staring down an unprecedented overdose crisis. Thank you. We have high-potency synthetic opioids like fentanyl and other often new and exotic variants, nitazines and so on, that are wreaking havoc in Canada and the United States. And so actually in 2022 in the US, we had over 100,000 people die. Almost 70% of those were linked to synthetic opioids, like fentanyl. In Canada, in 2023, we had 8,000 deaths, and 82% of those were linked to synthetic opioids. And so the reason behind a lot of that is because we have a large amount of unpredictability around fentanyl and what it can do. We also can't pick it up in looking at the drugs. So if there's someone who happens to be seeking out some heroin, you, by looking at it, can't necessarily tell. And even a tiny, tiny little bit can immediately kill you. And so that's driving an increasing risk. Now, in terms of the broader picture of why this happens, I think Amelia made a fantastic point in that we look at these things and have previously done so putting the onus back on the individual. It's your fault that this happened or that something happened, and that's a really, really terrible way to look at things because it ignores the broader context of what's going on. And so drug harms happen in social context and they must be understood in those social contexts. And so things like systemic stigma, things like structural stigma and structural violence, those are the factors that really, in actuality, contribute to what's going on. So we know that systemic violence is perpetuated against people who use drugs, people who inject drugs, people who overdose, because we have an inadequate system in place. We have structural vulnerabilities, things like stigma, things like, particularly in healthcare settings, stigma. We have inadequate wraparound services, funding, etc. I could go on about it for a long time, but what this does is perpetuate and increase health risks for people who use drugs. And that means that essentially they aren't getting equitable human rights. They are being othered. They are less than. We, our community, is less than. And that drives these horrendous outcomes. And so we can continue to put the onus on the individual, or we can, as a collective and as a community, look towards what those upstream factors are and how we're going to address those and what we can do to to either put in place in terms of a strategy or change the system entirely. Now, you might think that here in Australia we're immune to what is going on in other places. And many of you would have seen that Pennington published their most recent report yesterday. Well, in that report, you'll see that we are now at 42,000 deaths since the turn of the century, which is absolutely horrible. It's drug-induced fatalities. What I want to draw your attention to, though, is that unintentional deaths involving, and they lump these together, fentanyl, pethidine and tramadol. I just wanted to look at that number. In 2001, we were at 7. We are now at 178 in 2022. That is almost a 2,500% increase. That is huge. And if that keeps tracking, and as Amelia indicated, we've got AFP seizing, capturing fentanyl, 2022, 2023. We had some pings on nitazines and fentanyl as well this year. If that keeps tracking, we might be heading in that same direction. And that's not me trying to put a scare tactic out there or anything like that. That is data-driven. You can see Jace Ferris nodding. So you know I'm saying the right thing. In Queensland, that is effectively 1 death per 100,000 at the moment. And that might seem low, but every life lost that is preventable is still a horrendous tragedy. And as I said earlier, this is very, very literally something that we can prevent. And so in exploring that and trying to trace some of these elements from a lived living experience perspective, Emma and Steph and I looked at the role of synthetic opioids in overdose among people who inject drugs in Queensland, and we wanted to piece that apart a little bit more. And so Emma and I, as two AOD, alcohol and other drug peer researchers, co-designed the project from the very start, all the way through implementation, through the research, data collection, data analysis, and the write-up through the process. This is because, as Amelia indicated, peers significantly shape and can contribute to harm reduction, not just at a front line, throughout policy making, throughout research, throughout all of it. It is a key lens that we have ignored for a very, very long time. And so the need to elevate that is becoming more and more obvious. LLE peers can actively contribute. And so just want to draw attention to the fact that that is gaining recognition. This is another piece of work that showcases the importance of that. And because we did it that way, because it was with community, for community, by community, we had quite long interviews. Some people spoke for an hour and a half. Only really had to be there for 30 to 60 minutes. Didn't have to be there at all, really. But we had 30 people. They spoke for almost 70 minutes. As Amelia indicated, first opportunity for many people to actually share that experience with someone else. We had peer counselling and debriefing available, and there was a whole safety system in place there, which really should be standard practice. And so the data that I'm drawing from and talking about today comes from that report, comes from Voices of Lived Experience, and you can find that report right there. Takes you to the report. This larger sample, this larger people from our community, just want to take a moment to thank them for sharing their experiences and for trusting us, giving us that ability to be able to elevate their voices and present that and to help to make change, to drive change. So we are so lucky. Obviously pseudonyms, there's some other details there, but we drew down to 27 of those people who had experienced overdose and had used opioids to do so. I've put up a quote from Elias just to paint you a picture quickly. The thing that we heard, or the sentiment that was expressed constantly by participants when we asked them to tell us about how many overdoses they'd experienced or how many they'd witnessed. This came up so many times, essentially almost with all our participants. And then Steph had to press and ask because we wanted to try and quantify this. But I think this really encapsulates what we're here to talk about today. The fact that when you ask someone, how many overdoses have you seen or experienced, and they say too many to count, I think that more than anything else that I'm about to speak about should probably indicate that we have a problem. So we drew down 27 people from our sample between 34 and 73 years old, mostly identifying as female, 10 as male, 1 as non-binary, and 1 as gender fluid. In terms of the findings, we categorise these in two sort of themes using iterative coding from Joanne Neal. Used iterative categorisation, I should say. And I'm going to focus on Sebastian's story and trace that through both of the theme categories, but I just want to draw attention to a few other points. We have an unpredictable and toxic drug supply here in Queensland. I should also mention that all the participants were from Queensland as well, if I hadn't already. And this isn't something that's, just happening in US and Canada. This is here, this is now. And there was a few key points that I wanted to share that participants expressed. That is that there was a delicate balance between using and then having some withdrawal and then being a bit more risky in the use, so feeling sick and then using. And I think for me that pointed to the fact that things like OST probably aren't meeting requirements. That risk could be dropped down, could really cut that in half by having safe supply. But that's a story for another time. There was a bit of mixing drugs. We know that benzodiazepines potentiate overdose. We know that alcohol will as well. Any sort of polysubstance use adds to the complexity and the risk. And in the middle there was a period of abstinence that Sebastian had experienced, stopped using for a while, came back to use, and then what happened? For me, both times that I overdosed, I was starting again. I hadn't used in a long time, and so tolerance dropped. Perhaps Sebastian went back, and I think he did from the excerpt, and used a similar amount to what he had previously, and then dropped. And part of that, and what I want to focus on, is the inconsistent potency in the illicit drugs, because we don't have quality control on the illicit market. That illicit market is driven by those systemic socio-structural factors that I spoke about earlier, and so we have basically open slather for whatever to happen. We don't know what's in it. That's why things like checkpoint are so important. And so Sebastian went on to tell us directly about that unpredictable and toxic supply. Sebastian said that, I think it's fentanyl. People these days, overdoses are so much easier because obviously fentanyl is so much more potent. So there's no way of knowing how much you're using. These days, some heroin could be cut with fentanyl and you wouldn't be able to see that it's got the fentanyl in it, so you wouldn't know how much you're going to have. And it wasn't just Sebastian that said something like this. This was quite a few people said something similar. And what that means is that we've got an issue, if I haven't made that clear already, but that we also have solutions. Using alone increases that risk, and because of those systemic factors that I spoke about, we have a housing crisis at the moment. We have financial instability. We have people who are using alone. We have people in all sorts of environments. And that potentiates all of those risks that I spoke about earlier. If you are unconscious and no one knows that you're unconscious, how can someone help you, especially if you're in a private space? And so safe spaces can effectively mitigate some of those risks from death. And so Sebastian went on to provide us with a very, very straightforward example of a solution to that. Sebastian said, it's very difficult when you're homeless as well. You've got nowhere safe to be when you're unconscious. You've got nowhere to store your drugs. You've got nowhere safe to store your needles. It makes it all a lot more difficult. And that's why I think the safe injecting rooms would be a lot safer for people, to be monitored by someone. It would cut back on a lot of assaults, robberies, and overdoses. And so, framed within Sebastian's story, but also within all of our participant accounts, I think is the necessity to reevaluate where we stand on these issues, on these matters of concern. The fact that synthetic opioids like fentanyl are present, we see that not just in quantitative data, but also in the accounts of those with lived living experience, means that this is disrupting our current harm reduction practices. And so if it's disrupting what is currently happening, it generally means that we have the impetus to start to innovate. And so by innovating, we need to look at what our other options are. Luckily, Sebastian gave us one of those options. There's others, but I just want to focus on this one today. We know that Canada leads community strategies towards fentanyl, peers, naloxone, supervised consumption rooms. And because there's a rapid onset of fentanyl, because it happens so quickly, we also know that it's high potency. Sometimes we need more than one dose of naloxone, sometimes multiple. Sometimes we don't have more than one dose. And so what happens in those instances? Drug checking, from a study by Susie Nielsen and colleagues, they looked at the prevalence of fentanyl. I think they had a sample of about 900. They found a low prevalence, but they also had a lot of false positives and false negatives. And in the limitations, they stated that we need some more accurate testing than fentanyl test strips. Drug checking is great, don't get me wrong, but one other way to cut through all of this is supervised consumption rooms. And I'm not saying anything new. This is happening in so many places, happens here in Australia, just not in Queensland. This isn't something unique or even different, but it is very, very important. They reduce overdoses, and as far as I know, nobody's died. I think Paul Dietz said this maybe 2 weeks ago, and he's very much across it, so I'm going to trust him on it. He said nobody in the world ever has died in a supervised drug consumption facility, room, centre. So quite literally saves lives. And so what that says to me is that perhaps we should look at this, particularly given that Queensland doesn't have one, and that we have all these factors, both locally and globally, telling us that we should be prepared, innovate, and do so early. And so they don't, just to add to, although I don't think this needs to be sold as an idea, but just to add, these places don't just save lives, they also provide points of community connection, points of health referral, points of, for peers to be able to deliver that safe space that they carry with them, moves beyond the physical. I think also provides connection and all those other opportunities to deliver health conversations or conversations to meet those structural factors that I spoke about. So things like homelessness, financial instability, so on and so forth. So far beyond just the life-saving. And so implementing one here would probably be, or multiple rooms. See, we're using the word rooms, I think, would be a sign that we are paying attention to the voices of LLE in our community, that we are paying attention to the data, that we are innovating, that we are doing what is necessary to protect our community. If I can add one more thing, it's that economically this makes sense as well. It reduces burden on health and emergency services, and Emma doesn't particularly like the economic argument, and neither do I, because it dehumanises the issue. But there are multiple reasons to do this that will, I think, make sense for everyone. The last thing that I want to plug is that these initiatives are community-led quite often. And again, being community-led and being QuiVAA, I think what we need to do is listen to those voices, listen to the lived living experience, be led by it. We don't have to think up any magical strategies. The strategies are there if we just listen and then enact based on that evidence. And so I think really taking fulsome account of those LLE perspectives, listening to peers and being driven and led will really bring us to a better space to be able to reduce harm and save lives in our community. Thank you.